previous session we had discussed about the gastric cancer. Now, one more, a relatively less common variety of the tumor in the gastrointestinal tract is a gastrointestinal stromal tumors, which are related to the small intestines, as well as any of the other parts of the gastrointestinal tract. Now, it's a very rather relatively less common variety of the tumor, which is of mesenchymal origin and presents as a huge mass, and most of the times it remains asymptomatic. It can present in any location of the gastrointestinal tract, and majority of them are seen in the stomach. 60% of the lesions are seen in the stomach, and about 30% are in the small intestine. In the colon and the rectum are relatively less common varieties, as it's 5% in the colon and 5% again, less than 5% in the esophagus and in other areas of the gastrointestinal tract. And it's a sort of sarcoma. It's a connective tissue tumor, and hence it presents as a hard mass, a big mass, and it's the incidence as per the data is it's around 10 to 15 per 100 population, 10 million population and per year, and the median age of diagnosis is around 65 to 70 years. That's as per the statistics. Incidence is increasing now every year. The reasons are not known, but as per the available data, the incidence is increasing almost throughout. And clinical symptoms are very vague symptoms. Most of the times, the patient may not have any obvious evident symptom. When the patients are investigated for some of the clinical features like endoscopic diagnosis, endoscopic examination, about 30% of the patients, they are diagnosed only during the endoscopic examination, where the patients may have some vague symptoms, and without any expectation they may be diagnosed. And 10% of the patients are diagnosed as emergencies, particularly small bowel obstructions. Now, I will explain one of the patients whom I have treated who presented with the same intestinal obstruction pathology, and around a few of the patients may present with the gastrointestinal tract bleeding either in the stomach or maybe the other intestines. Other vague symptoms are usually non-specific abdominal pain or discomfort, or early satiety, that inability to have fullness or having a fullness in the abdomen, and or maybe palpable abdominal mass. Palpable abdominal mass also is one of the issue. As per the data, it is rare, but one of the patients whom I have seen had presented with a mass. And the other clinical symptoms are exertional dyspnea, malaise, etc. Widespread peritonitis due to perforation could be another of the presentation. Usually endoscopic features which are seen when the lesions are present within the lumen of the stomach or lumen of the intestines, they are seen as smooth swellings over the surface. At times it could be on the extraluminal area where endoscopy may not be able to make out. You may have to have a laparoscopy or the other investigations required, and usually presents as a smooth surface lesion with a huge bulging, or occasionally it may get ulcerated and bleeding could occur. And the clinical diagnosis by biopsy, endoscopic biopsy, often becomes negative because it needs a very deep tissue collection, which often may not be possible. So endoscopic biopsy often fails to make the diagnosis because the lesions are deeper, and only 50% of the patients it may be possible, or less than 50% as per data. And repeat biopsy in the same area where the previous biopsy was taken may help in making the diagnosis. Ultrasonography images of the stromal tumors are typically seen as hard masses with some loculated appearances in the surface is quite thick. This kind of appearance is characteristically seen in case of the stromal tumor. So a stromal tumor may be suspected when ultrasonography shows such masses. CT scan also shows the same compact tissue, hard mass, which is either inside the lumen or outside the lumen. In this, it's extraluminal in the stomach area, seen as such. So CT scan is another of the option to make the diagnosis. CT characteristics, that's rather CT is considered to be rather the benchmark for the diagnosis of the stromal tumors, and the characteristics are based upon the size, either which could be in between 5 to 10 centimeter or more than 10 centimeter. If it is less than 5 to 10 centimeter, usually it presents as irregular shape with the heterogeneous density and either intraluminal or extraluminal growth. Now, the image which has shown is extraluminal, and there could be a rapid growth which may infiltrate into the surrounding areas. In the patients who have a size of more than 10 centimeter, it could be present with the locally aggressive, like there could be highly vascular, and the lesion may have some irregular consistency. Somewhere it could be softer, somewhere it could be harder, and there is a tendency for the metastasis within the peritoneum. Widespread peritoneal lesions could occur. MRI images also would have the same pattern, irregular pattern, the consistency, and a relatively high local malignancy issues. Classification or grading would be almost on the similar line. T1 is when the tumor is less than 2 centimeters in the largest extension at the diameter, whereas T4 is more than 10 centimeters. Lymph nodes, again the same issue. M0 is no regional lymph nodes, N1 is regional lymph nodes are in order. Metastasis M0, M1 as usual. The current protocol of the treatment is surgery is the definitive therapy, where it has to be removed, and radical and complete surgical extirpation is the only chance for the cure. But because it involves the gastrointestinal tract, often the surgery becomes difficult or maybe non-viable. It is also involved in the patients who may have metastatic diseases, but most of the times their surgery would be a palliative surgery, because you will have to remove a large portion of the gastrointestinal tract. The patient may require some supportive treatment, like either feeding this extraenteral or non-enteric feeding, like where you may have to put a feeding tube in, and then nourishment has to be maintained. If the tumor cannot be removed completely, a part of the lesion also could be removed by debulking, and it may help with the adjuvant therapy. The further patient condition could be improved upon by adjuvant therapy. Laparoscopic resection also has, as per the data, has improved the result. Now I will come to one of the clinical experience. It was in 2012. A patient presented with the intestinal obstruction at KMC Manipal, and it was diagnosed as a jejunal stromal tumor, and the patient was recommended jejunostomy for continuous gastric drainage, but patient didn't agree to that, and because the condition was considered hopeless, the patient's party was rather a poor patient. Patient visited our hospital and got admitted on 6/7/2012. Initially, because the patient had presented with intestinal obstruction, I had started with the parenteral management. It was continued, that IV fluids were continued. Dashamula Nirogasti and Kanchanal Pularogya through the rails tube intermittently was given. Gradually, the patient condition improved. One of the things which I have in that patient, there was a huge mass, big mass, more than 10 centimeter size mass, which could be palpable. And during the clinical examination, they were regular follow-up. If we twist the mass to a certain, that the whole mass was relatively movable. If the mass was twisted to a certain position, the patient would have a movement, bowel movement, and the patient would pass the stools. Whereas if it gets retwisted, again the patient would develop the obstruction. So by repeatedly twisting this, we could just manage the patient to have oral feeding. Gradually the condition, the obstruction relieved. Though the patient was not ready for surgery, because of this possible twisting and then clinical improvement, I insisted upon the patient's surgery, and the patient was not ready for the tube, that feeding tube. So I promised that the patient would not have a feeding tube. We will try to have some other conservative option. And laparotomy was performed on 7/8/2012. On laparotomy, the lesion was seen as quite huge lesion, and a removal was impossible. And with metastasis, peritoneal metastasis also was seen in that condition, and complete removal was not possible. Now, I did a surgery which probably was
ಅಲ್ಲ ಮಿಸೆಂಟ್ರಿಕ್ ಮ್ಯಾಲಿಗ್ನೆಂಟ್ ಒಳಗೆ ಹೋದರೆ ಸಾಕಿಲ್ಲ ಅದು ಇಲ್ಲಿಗೆ ಬರಲ್ಲ. ಇಲ್ಲಿ ದಿಸ್ ಈಸ್ ವಾಟ್ ವಿ ಕಾನ್ ಡೂ ಎನಿಥಿಂಗ್. ಓಕೆ, ವಿ ಕಾನ್ ಡೂ ಎನಿಥಿಂಗ್, ಕ್ಲೋಸ್. ಅದನ್ನು ಮಕ್ಕಳಿಗೆ ಆಗಲಿಕ್ಕಲ್ಲ. ಇಲ್ಲಿ ನೆಕ್ಸ್ಟ್ ಇಫ್ ಯು ವಾಂಟ್ ಟು ಹ್ಯಾವ್ ಎ ಫೋಟೋಗ್ರಾಫ್. ದಟ್ ವಾಸ್ ಕನ್ಫ್ಯೂಸಿಂಗ್. ಸರಿ ಬಿಡಿ, ಅದೇನು
surgery well, and the whole issue was the patient had recovered well, patient was able to take the food orally, patient was maintained on Kanchana Arogya Kumari also, maybe with intermittent some other modification of the treatment as per the clinical presentation, and the patient was actually patient continued for about 3 years with almost a relatively healthy life, and by 2015 November she died due to some stroke, but not due to the complications of the malignancy. The size of the lump had not reduced. The patient had that mass as such, but the patient was comfortable with that. She could manage it, and average cost of the medicine was around ₹7 per day. As per the standard protocol of the treatment, the standard guideline would be radical excision with the imatinib, and the median survival period is 10 to 12 months, whereas this patient has survived almost around 3 years, and even after 3 years the patient didn't have any complication of that. The current market rate of imatinib is around of course when I said this current market rate, in the sense at that time 2012 it was around 3,200. Now of course the current rate is 300. It has been reduced now, so of course that current, in the sense the market rate at that time in 2015 was 3,200 per packet, whereas the patient could be managed with the medicine of ₹7 per day and somewhat comfortable. That's all. That doesn't mean that every patient of stromal tumor can be managed. The only important part is if the patient can maintain the oral food intake, and the drug, our drug can be administered orally like Kanchana, the clinical course of the disease can be managed. That's all the issue message. It's not that it's the same thing. And at times in surgery you may have to adopt many techniques which are not mentioned in the text, or which are not the standard practices, something unusual. Maybe at times that instinctual approach to the surgery also can produce some results. That's all the point. With this we will stop at that level about the stromal tumor. The next part of our discussion would be about hepatocellular cancer. Hepatocellular cancer, the incidence is increasing, and as per the prediction for 2024, the prediction of this hepatocellular cancer is American Cancer Society estimates around 41,630 new cases of liver in USA. Now this is about the USA data, and similarly the lesions are increasing throughout the globe. Worldwide, the liver cancer is earlier it was the 6th most cancer now earlier, whereas now it has become 3rd most common cause of big cancer deaths. So the incidence of liver cancer is rapidly increasing, and it's overtaking other cancers in terms of the incidence. And as per the worldwide data, in 2020 estimated this cancer was around 9 lakhs plus in every year, and 8 lakhs plus deaths every year. So that's the data. The source is here, so you may just read about that. Again the incidence is most in East Asia, including India, and it's around 17.9 per 1 lakh population, and the ratio is 26.9 in males and 8.9 in females. That's the statistical ratio. And Northern Africa, South Asia and Melanesia, the incidence is much more common. South Central Asia, the incidence is comparatively lesser. South America, the incidence is more. So there is a geographical distribution, and In America and Western Europe, the incidence is around 5.6 per 1 lakh. So there is a geographic variation as such. Etiological factors, the most common etiological factor and the most important etiological factor is cirrhosis. A cirrhosis persisting for a long time, patient would have a secondary or a hepatocellular cancer. It will develop into hepatocellular cancer. And the cirrhosis incidence is increasing rapidly because of the habit of consuming alcohol or the other food habits. Non-alcoholic fatty changes in the liver also is a precursor for the cirrhosis, and even the exact causes for the non-alcoholic steatohepatitis or non-alcoholic hepatic pathology is not yet hepatic fat changes are not yet fully identified, and the incidence is increasing, and hence the patient would have a gradual progression of the fatty changes into the cirrhosis and then develop the malignancy. About 80% of the patients who are diagnosed with the hepatocellular cancer would have a previous cirrhotic changes, and hence once the cirrhosis is identified or the risks of the cirrhosis are preventable, and once the cirrhosis is identified, further progression can be arrested with some medical intervention, and hence there is a scope for reducing the incidence of hepatocellular cancer with our medical treatment, our protocol of the treatment, particularly the Ayurvedic protocol of the treatment. Then the other factors are which are known to be a cause for the hepatocellular cancer are obesity and diabetes have been implicated. It's statistically identified, and particularly due to the development of the non-alcoholic fatty changes in the liver, which can result in the cancer, hepatocellular cancer. Alcohol is of course well known, and approximately 50% of the US American hepatocellular cancer patients have histories of alcohol abuse. It's not only in USA, everywhere it's the same. Maybe in Eastern countries the percentage may be more. 50% of the alcoholics may have the subclinical hepatocellular cancer at autopsy. Many of the patients may have hepatocellular cancer, but they might not have been diagnosed clinically. They might have been diagnosed as something else, and at autopsy it may be seen. Another of the important causes is the hepatitis B virus infection, which is claimed to super patients who have hepatitis B virus in the as a dormant condition, and the patient may not have a symptom. HbA3 positive patients, they may develop into hepatocellular cancer, and it's again a statistical risk. Of course, there is a lot of we have followed many patients with the HbA3 positive, and very few of the patients have developed the cancer. So it's purely a statistical fact. But incidence of HB virus, hepatitis B virus is increasing, and it is considered to be around 296 million in 2019, and it's claimed that it is related to the increased incidence of hepatocellular cancer. And HC virus also, hepatitis C virus also has become a pandemic now, and the incidence relationship between the hepatocellular cancer with the HC virus is quite high. It's around 5%. And the other causes are hemochromatosis, like where the patients who have excess of the pigments in the blood, like higher level of hemoglobin, higher level of iron in the body, such conditions, and particularly iron related, those who have more of apoferritin in the body, they tend to have the cirrhosis, and then later resulting in the hepatocellular cancer as such, and that would be more. The food, particularly containing fungal contamination of the food, would have toxins called aflatoxins, and aflatoxins have a very direct relationship with the hepatocellular cancer. Clinical presentation, the most important clinical presentation is a jaundice, particularly deep jaundice, and because of the deep jaundice, the patient would have itching throughout the body. So pruritus and jaundice is the most important and most common clinical presentation. Almost 99% of the patients of hepatocellular cancer present with jaundice. That's the important issue. Whereas the primary tumor of the liver, hepatoma, rarely presents with the jaundice. It or maybe only in the later stages it presents with the jaundice. The other clinical features would be splenomegaly, or there could be bleeding from the gastrointestinal tract, varices, esophageal varices, weight loss, abdominal girth increasing due to the ascites, development of the ascites, and hepatic encephalopathy. The patient may have a hepatic failure, and the patient may present with the hepatic failure symptoms, which are common. So, in our setup, majority of the patients will present with the ascites and the jaundice. So, any patient presenting with ascites and jaundice has to be investigated, and it's quite difficult to differentiate between a cirrhosis and a malignancy, and that has to be made out mainly by histopathology. Investigations, of course, like CT or MRI can give some clue about this possibility, but the exact changes, like whether it has resulted in malignancy or not, that has to be made out by the biopsy only. The important investigation which would be useful and in our limits would be ultrasonography. Ultrasonography has the lesions which may present in two forms, either type 1 or type 2. Type 1 is with the halo, that's the surrounding area of the lesion. There would be some areas of lesser density, something like extra these surfaces, like layers over, that's what we call as a halo. Or it could be without halo, which is infiltrating. So non-infiltrating or infiltrating could be the lesion. And there again, in the without halo, the lesions which are presenting without the halo, they are again categorized into three categories. 2A is where the patient would be having a homogeneous, the surface is homogeneous and the density could be more hyperechoic, that's what you see in this image. Or it could be type 2B where it could be hypoechoic, the smooth margin, or it could be with the irregular margin. As far as the progression is concerned, type 1 will have relatively slow progression, whereas type 3, type 2C would be having very rapid progression, and that could be somewhat related to. And the sensitivity of hepatocellular cancer by USG in hepatocellular cancer is just 45.7, but specificity is 100%. So you may not miss the lesion with the ultrasonography, but for these grading and other issues, the sensitivity of USG would be comparatively lesser. The CT image is again is quite useful, particularly smaller size tumors. They are better made out of the CT, and the sensitivity is significantly lower for lesions which are less than 2 cm, and contrast enhanced CT would be necessary to improve the detection, and usually a triple phase enhanced contrast CT is included in, and the lesions would have when you use the contrast, that the portal venous spread of the lesion, that dye through the portal venous, or late wash out, like whether the dye will go out after a certain period of time and the time used, they will give you some idea about grading of the lesion. Then another of the issue or investigational tool which would be quite useful is MRI. MRI has a high sensitivity and a high specificity, and the MRI sensitivity is around 84%, specificity is 93%. That's an excellent one. So chances of missing the diagnosis with the MRI is lesser, and contrast enhanced MRI also can make out much more. The quality could be improved. Smaller size lesions also may be difficult, but still it's much better than the issue of CT scan. Cirrhosis changes can be easily made out, but whether the cirrhosis has changed into malignant hepatocellular cancer or not, that may not be very clear or very accurate as such. So there you may need the biopsy. Now, as per the standard protocol, the radiology protocol, the guidelines for interpretation would be, if the size is less than 1 centimeter or more than 1 centimeter, and it shows the enhancement when you use the dye, contrast dye. It shows the enhancement of the arterial the space. See, when you administer the dye, initially it will be flowing to the portal veins. So in a triad of the liver, the peripheral areas would be having the dye initially, but later on it will reach to the arteries and then hepatic artery, and then the hepatic arterial dye would be showing the dye. Now this enhancement of the dye in the hepatic arterial area would be the diagnostic feature for the hepatocellular cancer, and the size and the time taken for the washout of the dye is considered as such. Now, as per the MRI scan, there is a standard protocol of getting the diagnosis or making the diagnosis interpretation, that's called LIRADS. Now, when you refer a patient for a MRI scan with the possible hepatocellular cancer or liver pathology, usually the report would be having these codes LR1, LR2 or LRM and so on. The meaning of this is, when you have LR1, it definitely benign, a lesion which is absolutely benign. LR2 is likely benign. LR3 is intermediate likelihood of hepatocellular cancer. LR4 likely hepatocellular cancer. If the diagnosis repeated is now the report is saving LR5 is a definitely hepatocellular cancer, and then TIV, the tumor in mean, which is not very specific, and LRM. Now, whenever you refer a patient or for the MRI scan here, most of the radiologists, they will give the report only within this LR1 to LR5. LRTIV and LRM, that type of the specification is rarely reported by the radiologists here. So anyway, that's about the standard protocol. What I mean by this is the images. Suppose you get the CT image. If the image shows a clear-cut border, size is small, the surface is smooth, then it's definitely benign. Even that when you use the contrast within the lesion is lesser or absent, then that's also suggests you have a LR1. So LR1 will be of that sort. LR2 will be having the contrast taken up, but the contrast will be in the portal spread. See, you will see that in the portal triad, the periphery has the contrast. The density is not very high. It's still not very high density as such. Size is small. It may be likely to be benign. You will have to wait and watch. LR3 is when the patient, the dye is taken up by the lesion, and the lesion shows a bigger size, comparatively bigger size, and you will have the arterial phase, the portal phase and arterial phase of the dye taken in, and it's a washout. It has got drained out rapidly, much more than rapid than compared to the other areas. Then a rapid washout is seen in the later phases. If the MRI shows that kind of image, that's LR3. LR4 images, the lesion would be having a irregular border, a rapid arterial take, and much more rapid washout features, then it's a likely cancer. And LR5 is where the density is irregular, highly irregular, and very rapid washout seen with having a line-like appearance, the capsule left over, that would be a definitely hepatocellular cancer. So, if a MRI image is having these features, that's a rapid intake of the dye, rapid washout of the dye, and the dye taken in both arterial and portal phases, that would be almost definite that the patient would have a hepatocellular cancer. So that's how it is made out. And LRM is malignant, but may not be very specific for the hepatocellular cancer, where the surface is highly irregular, there could be some halo around the area, and the tissue may be heterogeneous, then it's like malignant, but whether it is a hepatocellular cancer or not. So that's how it's made out. So MRI scan is one of the important tools to make the diagnosis. Tumor markers also are often used to confirm the diagnosis in hepatocellular cancer, and one of the most commonly used tumor marker is alpha fetoprotein or AFP, which is widely used and have a high sensitivity, low sensitivity and specificity, because it may be present in many people who may not have the liver pathology. even it may be slightly elevated in the patient of hepatitis. So there the interpretation has to be made up based upon the other aspects. So in our situation in India, most of the times the tumor marker used is only alpha fetoprotein. Other alpha fetoprotein variety like L3 and DCP, that's des gamma carboxyprothrombin, or GPC3, that is glypican. These are some of the newer tumor markers which are not so frequently done, and their accuracy also is doubted, but from the theory point of view, these are the tumor markers. Once a patient comes in of a hepatic pathology, the first of the approach before you plan for the treatment would be to assess the severity of the condition, and to assess the severity of the condition of hepatic involvement, we usually use a child-pug score. This is quite important, and that based upon the clinical signs of encephalopathy. If the patient has signs of encephalopathy, again, if the patient doesn't have signs of encephalopathy, patient is fully conscious, alert, and he is absolutely normal otherwise, as far as the orientation is concerned, then no, and that gives you 1 point. If the patient has a severe encephalopathy, then you give a 3 point. If the patient has no ascites, again the score is 1. If the patient has a huge ascites, score is 3. Bilirubin level, if it is less than 2, then its score is 1. If it is more than 3, the score is 3. And if the albumin level is less than more than 3.5, then the score is 1. If it is less than 2.8, the score is 3. Similarly, prothrombin time, if it's prolonged by about 6 seconds, then the score would be 3. Or INR, if it's more than 2.3, there again the score will be 3. Now, based upon this, the severity of the condition is assessed. If the patient has 5 to 6 points, it is considered as class A, which is comparatively less severe liver disease. In these conditions, usually the treatment protocol would be directly to the pathology. Like if there is hepatocellular cancer, the patient may be subjected to the chemotherapy or so on. And from our point of view also, from Ayurvedic point of view also, we can manage or we can make some changes in the clinical outcome. Like Kanchana, Aragyotin, Kumari also, with that the patient may have some changes in the outcome. Whereas patients of class B, 7 to 9 points, it's moderately severe, or more class C conditions, if they may require a more energetic intervention to improve the general condition of the patient. The target would be to treat the signs of encephalopathy or treat the signs of hepatic failure, manage the patient's general condition, than really tackling the basic primary disease of the liver. Metastasis is also common in case of hepatocellular cancer. Extrahepatic metastasis occurs in 30 to 50% of the patients, and the lungs are the commonest site, followed by lymph nodes and bones. The other rare extrahepatic metastasis would be adrenal glands, peritoneum, diaphragm, the soft tissues. Otherwise, brain also can be one of the sites. Oral cavity also could be a site where the metastasis could occur in liver pathology. Prognosis is the prognosis is quite poor. Overall prognosis for survival is very poor, with 5-year relative survival rate of 21.6%. This is in advanced countries like USA, where you have more facilities, whereas the survival period in our situation is much lesser, and the exact data is not known from India, but I am sure it's much lesser than that. And if the patient has if the patient is in early stages, first stage, then 5-year survival is around 37.3%, whereas if the patient has advanced condition, the survival percentage would be 3.5%, even with the advanced facilities in countries, economically well situated countries. The situation is in India much worse than, but we may not have the exact data. The treatment protocol would be, before you start with the specific therapy, the improvement of general condition, that hepatic failure symptoms have to be treated, like restriction of sodium, diuretics like aldactone, paracentesis or for the ascites, drainage of the fluid, then for encephalopathy, lactulose or irresolute or for variceal bleeding, the varices may have a band-aid, and antibiotics for bacterial peritonitis may be required. So that's the whole protocol of treating hepatic encephalopathy has to be followed, and only when the patient recovers from that, then the specific treatment is followed. The specific standard protocol of the treatment as per the guidelines would be surgical resection and liver transplantation is the only chance for cure but have limited applicability. The main prognostic factor for resectability are tumor size and liver function. And important is only about 5% of the hepatocellular cancer patients are suitable for transplantation. So scope for the surgical excision removal and transplantation are comparatively lesser, and this also is data from the advanced countries. In countries like where the facilities for these are comparatively lesser, the outcome would be much poor. Then there is another technique of improving the general condition, that's chemoimmobilization, directly injecting the chemo drugs into the tumor, or radiation therapy directly into the area, liver area, or brachytherapy where we insert the radioactive substances. Then systemic therapy, chemical, these drugs are used as such. So that's about the hepatic cancer, hepatocellular cancer. With this we conclude today, and in the next we will continue with the other types of the hepatic tumors. So if there are any questions, we will try to answer and then wind up today bit early. Right, there are no questions, so we will wind up today.